want to talk a bit about POEM, where it started, where it's come, or where it's gone in the last few years. And in here and dotted around here is investigations and the way that you manage and work up a patient with an esophageal motility disorder and decide whether or not they should have a POEM. And of course, having a POEM is a bit like saying, you can have a car, right? There are many types of POEM. There are many, you can tailor it completely to the patient by doing different length of myotomy, going further into the stomach, doing a selective longitudinal or circular myotomy, doing just a proximal or cranial myotomy. But I made this slide to illustrate how things which used to be dealt with surgically are now being dealt with endoscopically. And of course, one of those things, this is, of course, an ampulectomy, this is cancer resection, this is a huge submucosal tumor in the stomach, and this is a POEM. What types of esophageal motility disorder are there? This is not going to be new to you, but there are 3 types of achalasia. There is achalasia 1 and 2, and then in the Chicago classification, there is the spastic esophageal disorders, of which achalasia type 3 is one of those. Actually, these are the vast majority of things which we find, and the vast majority of things which you see. None of these conditions is common. And they showed in this meta-analysis that POEM is very effective. So the number of patients reaching the Eckhart of under 3 at these intervals of follow-up is around about 95%, 93% at 6 to 12 months. 24 months is pretty much the same, and there's no significant difference between these up to 36 months, and then a little drop off, but not statistically significant, from either 6 to 12 to 48 or between 36 and 48. What about safety? I see we have the patient ready, so I'll just wrap up this. Reflux is too common, and that's why I think we need to have a problem to solve reflux. In your helomotomy procedures, Kevin, are you always doing a fundoplication?
No, when I started practice, in my training, we didn't do them at all. That changed to doing them, partly because it protected the area that we'd operated on. Now, I would generally, it depends a little bit on the preoperative investigations. If they've got a big sigmoid esophagus that I don't think is going to empty very well, even after myotomy, then I would not do a wrap in those patients.
So, and the reason that you would not is because you're worried that it undoes the work that you've done.
Yes.
Yeah, and that's my big concern about the vogue which currently exists in the gastroenterology population, and intervention endoscopy population, of working towards where you guys maybe were 5 years ago, which is doing a fundoplication for endoscopic fundoplication after POEM. And so I do think that you need to select these patients carefully, and like you said, you need to select out the patients which are going to get fundoplication, because you can predict it, and we'll go into that later, patients that will get reflux. So when you talk about reflux, how many are using PPI after POEM? Quite a lot of them. How many are getting abnormal pH testing? Quite a lot of them. Erosive esophagitis. So in my experience, erosive esophagitis is much less common than this. I mean, 33, it's not 33%, it's maybe 3% or 3 to 5%. Stricture and Barrett's, very much less common. I've never seen a post-POEM stricture, but I do accept that it's definitely possible if you're going to really cut the junction more than once. And severe adverse events. And the ASG lexicon for adverse events is what they used to define them, 1.5%. So we'll go through later what those are and how you can best avoid them. This is now the best data for the efficacy of the 3 modalities. So POEM doesn't have 10-year clinical efficacy data yet. You may say, okay, well, that's the reason I won't use it. But just look at the efficacy of pneumatic dilatation versus either HeLa myotomy or POEM, and it should not be used anymore. So in my practice, I am never using pneumatic dilatation to treat achalasia. But reflux, yeah, it's interesting as well that this is similar between the two after HeLa and POEM. And I will just say the number of patients where you can't manage their reflux with PPI is very low. And I'd say it's about 1%, 1 to 2%. So PPI is the answer. The patients often don't want to take PPI all the time, and that's another story. But we do have the means by which to manage it.